For decades, direct supervision for contrast studies meant a physician was physically in the office suite. The CMS has made virtual direct supervision a permanent reality, and CMS will reimburse these virtual services at the same rate as on-site supervision. There is no pay cut. But virtual does not mean empty. A trained clinical staff member must be physically present with the patient. Here we will break down the exact technology, personnel, and documentation you need to be compliant. So, how did we get here? This permanent policy grew directly from the flexibilities of the public health emergency. The foundation is the redefinition of immediate availability. It now officially includes two-way audio and visual tech. This is still direct supervision. Personal means in the room. General means not immediately available. This new rule applies broadly across settings, from private offices and IDTFs to hospital outpatient departments. Now that we understand the what and where, let's get into the how. What specific technology does CMS demand? The baseline requirement is real-time, two-way, interactive audio and visual communication. This is non-negotiable. Because of this, audio-only methods like a standard phone call are explicitly disallowed. The physician must see the patient. But what does the compliant AV setup actually look like? The CMS and ACR guidelines go into surprising detail. High-definition, pan-tilt zoom cameras are a core requirement. The physician needs remote control of the view. Your network must be strong. CMS expects a dedicated bandwidth of 5 to 10 megabits per second and latency below 150 milliseconds. Why so specific? These technical requirements are designed to ensure the virtual supervisor can react as effectively as an on-site one. This technology directly addresses physician shortages, improving patient access for rural and community imaging centers. It improves efficiency by allowing one radiologist to cover multiple sites, reducing costs and canceled appointments. This isn't just a CMS mandate. It has strong professional backing from the American College of Radiology. The benefits are clear, but successful implementation has hidden difficulties. What must you prepare for? Recall our first point. You must have trained clinical staff physically present to treat any adverse contrast reactions. What if your technology fails? You must have documented backup protocols, including access to an on-site supervisor. CMS approval is only the first step. You must also comply with your specific state's regulations on telehealth. With all these rules, how do you prove you're compliant during an audit? The answer is rigorous documentation. Your records must be audit-ready, logging the supervisor's identity, availability, and the specific technology used. Common audit failures stem from poor documentation, like failing to log the tech used or how one person covers multiple sites. Let's connect these pieces. How do technology, staff, and documentation create a single compliant system? The AV system enables the physician's virtual expertise. The on-site staff provides the immediate, hands-on safety net. That specific pan-tilt zoom camera allows the remote physician to perform the visual checks of a supervisor in the suite. Your detailed documentation is your primary defense, proving compliant use of technology and protecting you from audit failures. This new standard rests on 3 pillars. Mastering them is the path to gaining the benefits without the risk. Pillar 1. Technology. Invest in compliant, real-time, two-way AV with PTZ cameras and a high-performance network. Pillar 2. Personnel. Ensure trained clinical staff are always physically present and part of the workflow. Pillar 3. Documentation. Create an audit-proof trail for every virtual supervision event, logging all details. CMS has permanently redefined direct supervision. This is the new standard.